go.
Today's podcast is going to discuss how pharmacogenetics can help drive antidepressant selection in the treatment of depression. First, I wanted to show a little bit about how the most common form of antidepressants, the serotonin reuptake inhibitors or selective serotonin reuptake inhibitors, how they act in order to treat depression. So we're looking at, in this first diagram, a serotonin synapse. That's the gap between two neurons where the neurotransmission occurs across that gap. And so the nerve ending releases serotonin. Serotonin is a neurotransmitter. It communicates to the other cell by binding to serotonin receptors on the other neural terminus. So when that happens, it stimulates the serotonin receptor and causes it to fire. And that causes the impulse propagation to continue and underlies the mental processes involved in serotonergic transmission. The way that the SSRIs work is they block the reuptake of serotonin into the releasing terminus. And what that does is that increases the amount of serotonin in the synapse and means that more serotonin receptors on the postsynaptic side will be bound by serotonin, stimulated by serotonin, and increase serotonergic neurotransmission. Now, in depression, on the postsynaptic side, the serotonin 2A receptor is the one that seems to be the most important for the antidepressant response. And what happens with that is that when serotonin binds to the 2A receptor and stimulates it, it causes a bunch of intracellular actions to occur. And one of these is the production of brain-derived neurotrophic factor, which is a growth factor that causes new neurons to be formed and new connections or new synapses to be formed between neurons. And that is postulated to be the basis for antidepressant drug action. I want to talk about a few different genes here that are important in selection of a antidepressant. So the first one is called MTHFR. MTHFR stands for the gene that encodes for methylene tetrahydrofolate reductase. Now, I know that's a mouthful. So from here on out, I'm just going to call it MTHFR, and I'll say that for both the protein and for the gene. Now, what does MTHFR do? Well, MTHFR codes for MTHFR, which is an enzyme which actually is involved in processing folic acid, which is a B vitamin, into its active form, methylfolate, which then can act in the body to do the things that that folic acid does. One of the things that's important about methylfolate is that it's a critical cofactor in the synthesis of the depression-related neurotransmitter serotonin. So if you don't have methylfolate, you don't make serotonin very well. And so this has people that have mutations in the MTHFR gene that results in reduced MTHFR function, they're predisposed to increased risk of depression, and the depression they have is very hard to treat. It's what we call treatment-resistant depression. So, and it's not an uncommon thing. About 20% of the population have deficiencies in methylene tetrahydrofolate reductase function. So this is a very common thing. It's also very well known. In fact, you can take methylfolate in a pill form as a supplement to replace the methylfolate you can't make if you're deficient in the MTHFR function. So, and this is known by FDA. In fact, methylfolate is a prescription drug as well as an over-the-counter supplement, but it's indicated by the FDA for the treatment of treatment-resistant depression. So the next gene that I want to talk about is the gene that codes for the serotonin transporter. Remember, we talked about that's where the SSRIs work by blocking that transporter, which normally would take serotonin back up into the releasing terminus and decrease the amount of serotonin in the synaptic cleft between the two neurons. So when you block that, it increases the amount of serotonin and it can stimulate the postnatral receptor. Well, the gene that codes for that transporter, is called SLC6A4. And it is also commonly dysfunctional in a pretty good percentage of the people. Up to 40% of people have some sort of decreased activity of SLC6A4 related to a couple of very, very common mutations. The first mutation for SLC6A4 is a deletion. In other words, part of the DNA is just gone in the promoter region, which tells the gene, the promoter region tells it, hey, we need to make more of this transporter. So when that promoter region has that deletion, it doesn't make the SLC6A4 gene start to be transcribed, and therefore you get a decreased amount of serotonin transporter. So what that means is that, and we call that the short version or the SS version. And what that means is that when you have decreased amounts of the transporter, then the SSRIs don't have a place to work, and they don't work very well in those patients. And so we're going to talk about how we use this gene and that deletion and its function to decide whether or not an SSRI is actually appropriate for this patient. So the long version or the LA version is the normal version of the gene. And then there's another mutation. It's not a deletion, but just a single point mutation that we call the LG version, but it acts very similar to the deleted form in that there's not as much expressed, and therefore it doesn't work. The SSRIs don't work very well. The next gene I want to talk about is the gene for brain-derived neurotrophic factor. That gene's called BDNF. So brain-derived neurotrophic factor is a growth factor that's involved in the formation, strengthening, and maintenance of the synaptic connections between neurons. And that's where all of the transmission and all the activity takes place. And as you can imagine, this is important in a wide variety of brain functions, and therefore mutations in brain-derived neurotrophic factor gene also are implicated in a wide variety of mental disorders. We know it's involved in the dopamine pathway and that it's involved in how you respond to antipsychotic drugs, as well as in how well you are predisposed for substance abuse. Again, a lot of these diseases are interrelated. And so a lot of times when you see someone with mental illness and brain-derived neurotrophic dysfunction, you will also see other substance abuse disorder, depression, other sorts of mental illnesses that are concomitant. And if you have psychosis, it's noted that you're 7 times more likely to have substance use disorder. And again, all these things are interrelated, and they have to do with essentially bad wiring because of a lack of BDNF to maintain the normal function of these connections between the nerve cells. So one of the things besides the addiction risk and relapse predictions that you can make from that is that we also know that if you have this particular mutation in the BDNF gene, that it also affects how you respond to SSRIs. Remember, the SSRIs work by blocking serotonin reuptake, increasing the amount of serotonin that binds to the 2A receptor and stimulates it, which then causes brain-derived neurotrophic factor to be produced. And that's really the basis for the antidepressant effect. However, if the BDNF gene is defective and you can't make as much BDNF, then SSRIs aren't going to work because you've essentially blocked them further down the therapeutic pathway. So I want to show you just a little graph here that is from a study that showed that if you don't have the mutation, if you're normal for BDNF function, then you're 3 times more likely to respond to an SSRI than if you have the mutation. So again, this is a predictor of whether or not you can respond to an SSRI. And if you can't respond to an SSRI, there are other categories of antidepressants that aren't affected by these mutations that you should respond to normally. One of those is called the SNRI, which is selective norepinephrine reuptake inhibitor. And that's another common antidepressant category that your prescriber can provide to you. Now, there are plenty of studies out there that have looked at pharmacogenetics and depression. Anyway, this is just showing you some of the results of some of the major studies. And that, anyway, the response of if you use pharmacogenetics to guide your selection of an antidepressant, you're more than double, you're more than twice as likely to respond to the SSRI or to the antidepressant therapy than if you just didn't use PGX at all and just treated people as usual. And also, PGX testing can also predict whether or not patients are likely to have poor outcomes when treated. And that makes sense, because if you're looking for the same mutations that are make someone treatment resistant, that makes sense that they would be more likely to have poor outcomes. And then another study showed that patients who had previously been prescribed medications that were genetically suboptimal didn't get any better. In other words, this is looking back. This is a retrospective study looking back, and it showed that people that had these mutations that affected SSRI function did not get any better when treated with SSRIs. And the last study I'm talking about is that patients, a lot of times what we do is we will categorize drugs as being red for no-go, yellow for you might want to use this, but there might be some precaution you want to take, and then green for there's no issue with this drug, go ahead and use it. So another study showed that patients who switched from a red category medication, which means that it was genetically incompatible with them, to a green medication that obviously has no genetic issues with that patient, that they experienced a 33% improvement in their depression scale symptoms. So I guess to reiterate, multiple scientific journals have reported, studies in these journals have reported that reducing depression and other symptoms, decreasing time to symptom relief, increasing compliance with their antidepressant regimen, and improving other considerations, that PGX has a beneficial impact in each of these categories of symptom improvement. A study of 165 subjects that were diagnosed with major depressive disorder, and they compared using PGX to guide their treatment versus just not using anything and just doing it treatment as usual, showed that the clinical decisions that were guided by PGX testing improved the time to depression relief, that medication identified as genetically suboptimal were prescribed to patients, and that if you changed those, there was a definite improvement. And also, people that had PGX guided therapy had a 4-fold greater improvement at the 8th week of observation. That's a huge difference. And then also, because the patient's getting better, the physician-patient relationship also is better, and they get positive feedback on the effects that PGX testing did in their treatment of depression. So I want to go through just a quick treatment algorithm for how you could use antidepressant PGX testing in antidepressant drug selection. So you start off with the entire group of people, and you say, you come in, are SSRIs likely to be efficacious? Well, the first thing we want to do is we want to find out if their BDNF is normal, because if the BDNF gene is mutated and doesn't work well, they won't do well with SSRIs. Also, the serotonin transporter, SLC6A4, if it's impaired, they won't do well with SSRIs. So if those are normal, then the answer is yes, SSRIs would be expected to have efficacy in this patient. Now, which SSRI you choose can also be guarded by pharmacogenetic testing by looking at by looking at the um, metabolism enzymes such as CYP P450 enzymes in order to pick the drug that's metabolized well. But you pick within the SSRI category and find those that are metabolized well, and that would work. If they're not okay, if BDNF is deficient or SLC6A4 is deficient, then no, you don't need to give them an SSRI. You need to use a different drug, such as a SNRI as a first-line therapy, or even the old tricyclic antidepressants, which work on a number of different neurotransmitter systems, also would be efficacious. But I would use those as second line because they generally have more side effects and are less well tolerated than SNRIs. So the other question we have to ask is, does the person produce methylfolate? In other words, are they MTHFR deficient? Because if MTHFR is deficient, they can't make methylfolate, then they're not going to be able to make serotonin. They're going to be treatment resistant, and you're going to need to supplement them with 15 milligrams per day of L-methylfolate. So if their MTHFR function is okay, then that's fine. If not, then supplement them with methylfolate. You would give that drug in combination with the SSRI. So thank you very much for this, for listening to this podcast, and we look forward to future installments on the use of PGX and medication selection.